Just a reminder, today's meeting is being recorded. Meeting room locked.
All right, so I guess we're live today on Wednesday, February 5th, 2014, presenting the Journal Club for MyLVAD.com. You probably can't read behind me, but I do have my I Love MyLVAD.com signs up here today, getting ready to celebrate Valentine's Day, and I'm happy you all decided to join us today. I'm presenting on behalf of Dr. Todd Massey in the Artificial Heart Program here at the University of Rochester. If there's anything but good news is that the snow that we got last night is a mere 20 inches of snow, and most of us are still here at work enjoying the sunny, white winter that we're having. So I hope you're all doing well. Those of you that I know, those of you that I haven't met, welcome to MyLVAD.com and the Journal Club, and we're going to go ahead and begin our presentation today, which is vadoscopy, an intraoperative technique to evaluate the HeartMate 2 in the setting of pump dysfunction. And the specific thing that is unique to this approach is it allows us a limited pump exchange without having to do a full inlet pump motor and outflow replacement, which I know probably many of you have attempted in your early diagnostics and assessments of pump thrombus or pump dysfunction. So we're going to talk about that approach that we use here at the University of Rochester, and we'll get going with that today. So my first objective is to discuss the evaluation of a dysfunctional LVAD, and the reason I want to emphasize this early on and discuss this in this part of the Journal Club is because to do a limited pump exchange, your diagnosis that the pump motor is the only dysfunctional component of the VAD system becomes very important because we're not only talking about the vadoscopy, we're discussing just using a limited subxiphoid approach and a small intercostal incision to put a clamp on the outflow graft. So it is very important that as we talk about LVAD dysfunction, that as we enter the operating room, whether it's the surgeon, the cardiologist, or the VAD coordinator doing that initial assessment of pump dysfunction, that we're pretty sure of the diagnosis that we have going forward. The vadoscopy is going to allow us to confirm the diagnosis of isolated pump dysfunction or motor dysfunction because, as we know, the inlet's a very difficult thing to see down into, even with the advent of 3D CAT scan. So we're going to talk about the evaluation of the dysfunctional LVAD. We're going to discuss the indications then for a limited pump motor only device exchange, and talk about the approach for the pump motor exchange using the subxiphoid approach with vadoscopy. So when we talk about LVAD pathologies, you know, this list can get very that we have a dysfunctional VAD, we have a patient in heart failure, they appear very sick, and it's a situation that makes it very difficult to see past that. But when you're the person managing these patients as the VAD coordinator or clinician, you know, your diagnosis of what really is going on besides just I have a pump that's not flowing well becomes really important when we talk about the timing that we may have, the strategies that we may be able to deploy to reverse this situation, and the eventual outcome for the patient. So when we talk about the inlet specifically, the things that we need to consider is that there's an obstruction, whether it's myocardial obstruction, myogenesis, which we have seen, intraventricular thrombus or a tulip thrombus or pannus thrombus that may be overriding the inlet, malposition of the pump. I think those of you that haven't seen it yet, the advent of patients whose body habitus changes over time as they enter in from the ideal body size that we implanted them on to potentially the obese body size, that inlet can then be malpositioned into the septum. Inlet stenosis, which is usually secondary to that offset inlet position, inlet invagination of the graft, which hopefully we don't see anymore, but was an early pathology that was seen, along with the graft boot stenosis that also hopefully is no longer around, but the potential still exists for both of those pathologies to happen. Any of those pathologies of the inlet will either require a revision of the pump inlet or actually replacement of the pump inlet, depending on what we have. And really just a pump motor exchange will not be the correct approach. However, when we're dealing with a pump motor primary dysfunction, whether it's electromechanical PERC lead fracture, separation of the lead from the pump, pre-rotor inlet obstruction, or a rotor bearing thrombus, or secondary rotor flow obstruction, which is usually a sudden ingestion of particulate or thrombus matter from the left ventricle. We've seen that here related to patients who have had innocuous malignant ventricular arrhythmias that develop mural thrombi that then wind up into the pump. Can definitely be a good pathology that just a pump motor only exchange is the thing to do. Outlet post-rotor flow obstruction is generally seen with the bend relief displacement, graft stenosis or compression, and a stenosis occurring at the anastomosis of the graft to the aorta. Also something that will require an open revision usually and almost a near full replacement of the system. When we talk about our conventional diagnostics, I think all of us are very familiar with seeing a patient. Potentially they have new onset heart failure, they have elevated LDHs, maybe hemolytic anemia. A lot of them have silent pump symptoms in the beginning, meaning they may have nominal or fluctuating power increases, and we begin an evaluation of what's wrong with the pump. So at first, we always have to remember to compare what is their heart failure at baseline. Hopefully they should have no symptoms, and look at what are we dealing with. A lot of times we're seeing RV dysfunction or pulmonary hypertension mimic a dysfunctional LVAD. It can definitely lead to a dysfunctional LVAD as the LV becomes underfilled over time. You have high inlet velocities with a slit-like LV, and you can develop an inlet thrombus that eventually leads to pump dysfunction, but the primary cause has potentially been RV failure or pulmonary hypertension that has led to the LV being empty. So we have to look, early on what really is going on. Is this right heart? Is this left heart failure? What's their exam at baseline? We've explanted 6 pumps, and actually sometimes late, out of patients that present with hemolysis, a pulse, and no overt signs of heart failure. And really the genesis of the pump thrombus has been recovery of the heart, and after that they have progressed to thrombosing the pump. With those patients, as I think all of us that have managed pump dysfunction know, they can become sick from this very quickly. So there's a narrow window where you might have someone present with recovery, but then progresses to a dysfunctional pump, and then becomes sick because of that, because of hemolytic anemia and hemolysis. And we don't want that to happen. So and very quick recognition of cardiac recovery is pretty important. What is really happening with the patient is do they have a sense that the pump is going on, off? The analysis of the PERC lead wire becomes important. And then as we move forward to the diagnostics, I think we're all very familiar with assessing the X-ray position of a normal pump by angle to the lateral wall, position of the outlet, making sure it's not overriding the right ventricle, so the right of the sternal border. Looking at the right heart caths, they should have normal hemodynamics with a low wedge pressure. Whether we use initially a transthoracic echo to correlate the findings of left ventricular function to PI that we see on the device, assessing normal velocity more at the outlet during diastole. That should be your number one question during these exams. Is before going any further, do you have a normal diastolic velocity? Is there blood flow at the outflow graft during diastole? If you have that, you pretty much should have a at least functioning pump with flow being generated by the pump motor. More invasive testing would be the transesophageal echo with VTI calculations of flow actually at the outflow graft is a ramp test. So as you ramp the speed and what correlate your normal ramp test for that patient in terms of when to close the outflow graft, what would the VTI flow velocities from previous tests should give you a correlation between what's happening today and what was happening with the pump when you didn't have any signs of dysfunction. A CAT scan of 3D reconstruction is a good test, but is still limited to what we can see on the inlet. And of course, we can't see anything in the pump motor itself. Continuity tests of the PERC lead. Obviously, if you're doing a cutoff test, we want to make sure that we don't have any thrombus, any subaortic thrombus that could result from opening the aortic valve. And we often will perform an angio assessment of the outflow graft looking for gradient or stenosis changes along the graft to diagnose outflow graft stenosis. When we have a dysfunctional pump, obviously we're faced with a couple choices. We can consider the patient for transplantation. If it's recovery, we can consider explant to recovery. Those of us that have tried, or you may still be trying, thrombolysis is something that can diminish pump dysfunction and allow the patient to recover a little bit and may lead to resolution of device thrombosis. Device revision, if it's an offset inlet due to malplacement from obesity or changes in the heart walls, this can be something that I know many of us have done to kind of pull the heart down and in, or put displacement devices inside the thoracic space to keep the inlet in an ideal position. Or what we're going to talk about today is device pump motor or component replacement and how we're going to approach that. I think it is important to discuss that is any patient that presents with pump dysfunction, diagnosing it quickly, diagnosing what is dysfunctional and treating them in a timely manner, I think is very important. I think we've all at times had a patient with a dysfunctional pump that we took a less aggressive approach and maybe waited, and these things can quickly escalate from what may be an innocuous thrombus or bearing to a larger thrombus, to embolic events, to the patient becoming sick from hemolytic anemia, to multi-system organ failure, and even death. So I think that there's an initial presentation with pump dysfunction can really escalate quickly, and a multi-system approach to deciding what to do within a short period of time is crucial for good outcomes with these patients. So what we're going to talk about in the Journal Club is this, the vadoscopy approach that was presented in the SIO last year by Dr. Chang, Dr. Schwartz, and our primary surgeon here, Dr. Todd Massey. So when we look at our imaging modalities, I think that these are great pictures to have, but one of the problems becomes we cannot see well the inlet. Right here, we cannot see the inside of the pump motor, and so we're limited on what we can see. We can see a little bit of the graft here to help us with graft stenosis, but we can't see whether there's inlet thrombus there. TEE allows us to see the space above the left ventricle to look for obstruction there, but in our diagnostics should lead us to whether or not there's a problem in the pump. This began early on when we had a patient, as you see here. This is actually inflow graft invagination, so this is looking down the inlet of the pump, and it's something that I believe with a good surgical approach we're going to minimize or have minimized and eliminated in the VAD world today, but it really was the first time that we had a VAD dysfunction in an area of the pump that we were blinded to and couldn't see, and this patient obviously had low flow, had hemolysis, had silent, what we call silent pump death because of power and PI. Although PI was influenced, power was nominal, pump flow readings were nominal, and we really didn't, we weren't aware of this until the patient had succumbed to basically cardiogenic shock. So this really led us to a quest to how could we diagnose inlet device in a non-invasive way or a minimal invasive way without taking it out. And if we've ever done an LV gram with these patients, you just not fill LV volume enough without shutting off the pump to really light up this area very well. So what we used to do in the HeartMate 1 days with these the pulsatile pump systems to get good imaging of the pumps, cannot be done with axial or continuous flow pumps. And the quest was to also minimize the impact on the patient. We knew we could swap out the pump motor through a subcostal or subxiphoid incision, and wanted to provide the patient with a short recovery time without having to undergo a full redo sternotomy. So the objective was how could we image the inlet of the pump and lead us to the ability to just take out the pump motor. We were confident in our ability to image the outflow graft by CAT scan and by angiography, but the ideal situation was to just swap out the pump motor. So as you see here in this picture here, this is just a minimal incision. We have a small incision up top where we clamp off the graft, and we're just going to actually just explant just the pump motor itself. What led us to the thing that led us to image this was actually the idea to put a Fogarty catheter up the barrel of the inlet, occlude blood flow from the LV into the inlet, and be able to look up the inlet with a ureteroscope. So we came to this conclusion that this was a good idea. We underwent this with 6 patients that were undergoing pump-only exchange with the objective to see did we need to go back and replace the inlet. So all these patients had good inlet position. We had no evidence of obstruction from anything in the ventricle, and our belief was that we did not have any inlet problems and that this was a pump motor only problem. This being said, this goes back to the discussion about intervening on these cases early, because what can be a pump motor problem can quickly lead to an entire device thrombosis where the entire system is then full of clot, and we don't want that. So timely intervention on this is key to recovery, because with this type of small approach, we've had patients get their pump device or pump exchanged and go home in 3 days. And that's really what we're aiming for here, is a short recovery time, minimal impact to the patient, but definitely good diagnostics are important early on to make this happen. So the approach was just as I described. We use in the operating room a small incision. We take the ureteroscope, as you'll have read in the article, and place it up the inlet after we obstruct the inlet with a Fogarty, but with the balloon inflated, and we're able to visualize, after some irrigation, the entire inlet graft. This is the picture that we see. You can see in one shot the barrel of the inlet. You can see the balloon. This is the picture on your left. You can see the balloon inflated in the center of the picture. You see the lining of the inlet barrel, and then on either entrance or removal, you see the graft. So these are important things. I think, looking at a patient who has a dysfunctional pump and you think that this is an offset inlet and there may or may not be thrombus on the inside of the pump, or conversely, you're sure that this is a patient with stenosis on the inlet because the pump's acting normally, will lead you to a discussion with your surgeon about which way to go, whether this should be a full pump exchange or whether this just be a limited pump exchange. So for these cases, the confirmatory diagnosis is made at this point when we can look at up the inlet and down the graft. Now, the only real way that you could get into trouble with this is if you did have a pannus or tulip thrombus, but those thrombuses should be able to be visualized using echo contrast and good TEE to identify structures within the ventricle that are potentially coming into the pump and including your inlet. So I think it's real important that although you may have a competent graft and competent inflow cannula, making sure that there's nothing in the LV cavity that is obstructing the inlet that may lead you to make the diagnosis that flow is obstructed in the ventricle is an important thing to consider here. So for discussion going forward, I think that we're all going to at some time, whether it's because of things like recovery or ingested thrombus or patients that become hypercoagulable from states of infection, we're all going to have to deal with some sort of pump dysfunction at some time. I think having a good understanding and a good organized approach to device interrogation is extremely important into making the correct diagnosis. And once you have a good diagnosis of pump thrombus or pump dysfunction only, whether it's electromechanical with a percolated wire or something just between the rotors, bearings, or stators, I think this is an approach that can be used to really allow you to turn over a patient in a short period of time. Like I mentioned, we've had patients go home in 3 days after the surgery, feeling well again, free from heart failure without ever having multi-system organ dysfunction from the hemolytic anemia. And I think those are the components that are very important to making this approach successful for you. So with that, you guys can propose questions to us today, and we'll be happy to discuss them. Those of you that, and I think we can put out all our contact information here at the university, and Dr. Massey or myself will be happy to share any of the information that we have or we'll glean from doing this. And just as we'll present this to you guys, we're also very happy to hear anyone else's insight onto other approaches to this that will improve all our patients' outcome. So for that, I tell you thank you for attending the Journal Club today. Happy Valentine's Day, and I hope you're all staying warm somewhere, someplace safe. So have a good day, and I look forward to all your feedback on the Journal Club here.